Go.
Hi, everyone. We are here from the Vestibular SIG, and we are going to do a little demonstration today to show you how we do a vestibular evaluation via telehealth. So my name is Sarah Gallagher, and Sarah G will be easier for this presentation. And I am a physical therapist here in Denver, Colorado, and owner of South Valley Physical Therapy, which specializes in vestibular therapy. We have been providing telehealth for vestibular therapy for over 3 years, since 2017, in order to provide access to expert care. So I will turn it over to my colleague to introduce herself.
I'm Sarah Oxborough and Sarah O for this call. I work at the National Disease and Balance Center in the Twin Cities of Minnesota. And much like Sarah, we've also been doing telehealth for quite a few years, but it's recently ramped up. We did not used to do evaluations over telehealth, but recently we are. So Sarah and I thought it'd be great to share some tips and tricks that we've been using. We'll go back and forth, alternating between therapist and patient to show you different areas. So Sarah, why don't you kick it off with your ocular motor testing?
Sounds good. So I will be the PT to start this test, and Sarah O will be the patient, so you can see what it looks like from both perspectives. So Sarah, I'm going to have you lean in towards your computer, get up pretty close, maybe 6 to 10 inches away. And then what I really want you to do is concentrate on opening your eyes fairly wide. So I'm going to observe your eyes. Perfect. Now I'm going to have you follow my finger with your eyes, keeping your head still. Keep those eyes open, nice and wide. Did you lose me? Sorry.
That's okay, just a little.
Good, get all the diagonals. Good, good. Any problems with that?
Mm-mm.
Good. And then I also like to do a figure 8 pattern, open nice and wide, lean in just a little bit. Perfect. And as the PT, it's tricky because I need to watch her eyes, and I also need to make sure that my finger stays within the parameters of the video as well, too. And if there's a little bit of a delay, that can be a little bit tricky to think about. So next for saccades, Sarah, lean in, open your eyes nice and wide. I'm gonna have you look at this finger and then this finger, and you're gonna alternate in between. On your screen, these fingers should be about 4 inches apart, no more than 4 inches apart.
On my screen, they're probably close to 2 inches right now.
Okay, perfect. So I want you to look here, then here, back and forth as quickly as you can. Good, keeping your head still, good. And now we'll go this way. Good, perfect. Okay, so next I'm gonna do the cover test. So what I'm gonna have you do is, using your own hand, you're gonna cover one eye, and I'm gonna be observing Sarah's uncovered eye as she covers. So bring it away, open, nice and wide. So Sarah, perfect, just like that. I want you to cover, good, no movement in the uncovered eye. Let's do that again. So uncover, go ahead and cover, perfect. And now I'll have you cover the other eye, lean in, good, open your eyes and uncover, and then cover. And again, I'm observing her uncovered eye when she covers it. Okay, good. So now we're gonna do a slight variation of that. So Sarah, you're gonna use both of your hands this time, and you're going to do a cover and then a cover of the opposite eye. Good. And here you are going to observe the eye as it becomes uncovered. Good. Good. Okay. So next I'm going to have you, Sarah, turn in your chair to face sideways from the camera this way. Good. Now, just watching me, what I'm going to do first before you do it, I'm going to have you hold your thumb out and you're going to tell me if it's in focus. And then once it's in focus, you're going to bring it closer to your nose until it potentially turns double. And now you're going to stop when it becomes double. So go ahead, hold your thumb out, bring it, is it in focus?
Yep.
Okay, bring it closer to your nose, stop when it becomes double.
Right about there, maybe.
Okay, good. And then how much would you estimate that is away from your eyes?
Maybe an inch.
Okay, so looks to me like it's 4 inches from the tip of your nose, and so maybe it's around 4 or 5 inches away. So you could also have your patient use a measuring tape to measure how far away it is, and at least then that would be standardized. But having them turned sideways gives you a better perspective of how far away it is.
And you could also do it front facing if you wanted to watch for eye movement.
Yes, and I would, just to make sure that they're both converging and then diverging as well. Yeah. Okay, so, and then just an observation of eye position. So Sarah, you're gonna lean in and you're gonna look right at the camera. Good, and I might do a little gaze here as well. So go ahead and gaze to one side, looking for any gaze provoked nystagmus. Go ahead and gaze to the other side. Good, you get the idea there. And that's about what I do over telehealth for an ocular motor exam.
So I'm going to jump in now as a therapist and give you some solutions to look at VOR. Some other pieces that we typically do in clinic for examination would be block fixation, so using our infrared goggles. We're not going to be able to do that over telehealth, but there's a couple things we can do. So we do the dynamic visual acuity test as best we can. We kind of call it our modified dynamic visual acuity test. I'm going to try to pull it up on my screen. What I typically do is send the patient a link to an ETDRS chart, and we use the Doxy platform, so I'm able to just send that to them. Let me see if I'm able to share my screen here. I think we did those last time, didn't we, Sarah?
We did.
All right, here we go. So I'm going to, oh.
Hold on one second. Let me take myself off host, and then I think you'll be able to share a screen.
Okay.
Okay, try that again, Sarah.
All right, so I'm going to go ahead and try to share. All right, so I'm going to share my screen here. So are you able to see that eye chart there, Sarah?
I am.
Go.
Okay, so what I do is I send them a link to this ETDRS chart over the chat function in Doxy when we're doing it. You could also email it out ahead of time. And then I have them pull it up on their screen so that I can actually watch their head movement. So I'd like you to sit about 4 feet away from your laptop or your computer. And then once you get situated, make sure your computer is also at about eye level or slightly below. And then sit up nice and tall without leaning forward. And then go ahead and tell me, what's the lowest line you're able to read clearly?
NCKHD.
Good. Okay, can I have you bring your eyes to the top now? And I'm gonna have a metronome here. Now again, in the clinic, I'm usually doing this passively because often if there's a hypofunction, the person might start slowing their head speed down so they're able to keep the letters in focus. But I'm gonna instruct her to do it to the best of her ability to keep up with this metronome that I've got set here. So I want you to turn your head at this speed. See how I'm turning up my metronome?
Yep.
So it's pretty short and quick. And go ahead and start reading that top line for me.
HVZDS.
Good, next below.
KD. EZSHN. ONBSR. KDNRO. ZKCSV. VVOHC. OHVCK.
Good. Okay, I'll stop sharing my screen here. Okay, excellent. And then I always like to ask if you feel any symptoms after that at all.
I do.
Good. I'll usually make note of that. So again, not as not the best version. We'd like to really have that head and us kind of be in control, but it is something we could start to look for. Or I could note if she is slowing her head down and not able to keep up with the metronome, that might just be something for me to jot down as well. The head impulse test is another test that we'll do in clinic. That test also we want to be in control of because it's a really unpredictable, quick accelerated motion. Unfortunately, we weren't able to do that remotely. But what I can have you do is go ahead and scoot up to the computer so you're a little bit closer here. And then I just want you to keep your eyes on my nose while you go ahead and slightly rotate from side to side. And just start slow to start with.
Oh, okay.
Yeah, so just go slow like that. Yep, so this way I can just see if I see any difference with right to left movements. And then what I'm gonna have her try to do, can I just have you now look at my nose and just do a real quick movement to the left and a real quick movement to the right. Good. So in somebody who has a larger hypofunction, you might be able to see a little bit of that catch-up saccade happening. As we often see in the clinic when folks are doing ×1 viewing in the clinic, we'll often see towards one direction, their eyes just take a second to catch up, or that they can even themselves feel a difference. So I'll sometimes ask if they notice a difference, doing a quick motion to the left or to the right. Good. And then I think you had something along the lines that you screen with the metronome sometimes.
Yeah. So again, it's not a validated test, but if you can standardize it patient to patient, so using the metronome as well. So first I'll screen them just without the metronome. I'll have a patient hold their thumb up, and maybe not with the screen and behind them, but with a planar background, just so they're not getting dizzy from the screen, and have them hold it to the side. And then without a metronome first, I'll have them tell me if their thumbnail is in focus, and then start having them turn their head, observe what they can do, and then have them speed it up. Is it still in focus? Yes. I would have you do that, Sarah. So Sarah, go ahead and do that. Is hold your thumb up. Is it in focus?
Yep.
She's really restricting. So Sarah, go ahead and start turning your head more quickly. Can you keep it in focus in there? Good. And then a nice way to turn this into a homework is to set a metronome goal for them with that. So another, again, that's a screen.
And then I also like to look at VOR cancellation. A couple different ways you could do this. Again, in the clinic, we can be right up looking at their eyes as we hold their head and rotate on a stool side to side. But another way you could do it is, Sarah, go ahead and hold your thumb out in front of me, in front of you. And I want you to just move, let's just go about 45 degrees to either side while you keep your eyes on your thumb. And I'm going to try to observe eye movement. This is a little bit hard to do virtually, but at least I can kind of screen for any big overt red flags. And then go ahead and stop there. And then another option that you could do is if the person's got a laptop. So if you do have a laptop, what I'd have you do, you need a laptop and a rolling chair, is holding the laptop, focusing on the camera, and then they're just rotating themselves side to side.
Let's come in here.
Good. So that way she's got a fixated target of the camera and I can see the eye movement a lot better. And then again, I always like to ask for any dizziness with that one, since that seems to cause dizziness oftentimes in migraineurs or 3PD. Good, let's see, what else? So that's VOR cancellation. I think that works really well. So going into kind of motion sensitivity, you know, the other thing I wanted to comment on is we've tried doing the VOMs with a couple of our concussion patients. Again, not a standardized version, but at least gives us some objective info, and we can use it for retesting and also gives us guidance of where to start exercises. Most of it is along the lines of all the things that we've showed you so far. So we have been doing VOMs with some of our concussion patients. And then I think, is that most of the things for ocular motor?
Yeah, and then just for more for visual motion hypersensitivity, just the ocular motor can give you that asking about the symptoms of whether it's making them dizzy or not. I especially like this test will give you good information, especially if you have the screen behind them. So just having them move their head or just move their finger, but the motion, the perceived motion of the background is a nice screen for visual motion hypersensitivity. And
Yeah, and I think it's good if you ask a subjective rating and jot that down, like just doing a simple 0 to 10 scale, because then when you do reassess, especially if it's virtually, you can just kind of compare pre and post treatment that way.
And then another tool that you can use is just optokinetics on YouTube, is you could show a busy background and expose them to that and see if that makes them dizzy as well. So I pull up an optokinetic bar. Let me see if I can share my screen here. Can you all see that?
Mm-hmm.
So that's a nice way that you could have them pull up a YouTube video like that, and you could put a target and even have them move their head or move their finger and have that background behind them to see if that makes them dizzy as well.
Mm-hmm.
So another resource for you.
Speaking of motion sensitivity, the MSQ is another really easy test that you can start to do, where you can just take the patient through various motions, ask them to rate their symptoms from 0 to 5 and use a timer. In the clinic, it doesn't involve any hands-on. You can get by doing the Dix-Hallpike with a sideline test. We'll talk about BPPV later. Or you can have them do the traditional Dix-Hallpike for that test, either having somebody hold their head or just going slightly off the bed. So that's another standardized test that's been really easy and nice to do via telehealth.
Good. So next on our list was looking for a head writing or labyrinthine response. And the way that I like to do this in the clinic is on a tilt board seated, and tilt them and see if they have a labyrinthine response. And so, or an otolith response. And so the way that I do it in telehealth world is I just have them do seated reaching. So sometimes bringing their arms up here. Good. And now, Sarah, what you're going to do is try to reach towards one side. Good. And now I'm looking for Sarah to see if she keeps her head in line with gravity or if she tilts her head off to the side in line with her torso. So, and reach to the other side. Good. And if that doesn't elicit enough of what you need to see, then I'll cue people to reach as if they're reaching down this to pick up something like a pencil off the floor from their chair. Now you can see her shoulders are very tipped and her head is staying upright to gravity. Reached on the other side of the chair. We'll see if she has it on this side. Good. You can see her shoulders are very tipped, but her head is in line with gravity. And you can tell because the corner of her room gives that nice vertical reference. So that's a nice way to look if they have that reflex.
Good. So moving along in our evaluation, I don't always screen, I certainly screen cervical range of motion so that we all know how to do screening for any cervical spine contributions, such as cervicogenic dizziness. Sometimes we'll prioritize the center eval, but sometimes we'll save it for the next visit. If you think it's something you want to further look into, we know one of the tests is head repositioning accuracy, which is done best with having a little laser attached to a cap. So you could ask the person to see if they're able to get a laser. With Amazon shipping times being slow, that might be a little bit difficult to do. So that test, we haven't really done too much over telehealth, but one nice screen that you can do is kind of doing the body rotation under stable head motion. So what I'll ask the patient to do. So first thing, Sarah, I just want you to do is look over your right shoulder as far as you can. So I'm screening rotation with this, and then back to the middle. And I ask about any dizziness with that. And then same thing over the left side. Good. And then back to the center, any dizziness with that. Good. So now to try to get the head to stay center while the body moves. Again, if they're on a swivel chair, this makes things a lot easier. Are you on a chair that's able to rotate?
No.
Okay. So the next option that we have is to move the person into standing. So then what I want you to do is you're just going to stand up, and I want you to keep your eyes focused straight ahead on the camera. And I'm going to demonstrate. So I want you to keep your head still and don't let it move while you walk your whole body over to the right side. So it'll almost feel like your head's looking left by the time you're done. Good. And then any symptoms with that there?
No.
Good. And then go ahead and walk all the way over to the other side now. So this way I can kind of take the vestibular system out of it and look at just pure neck rotation and then back to the center. And then the other piece I like to do is take the neck out of it and move the whole body. So now can I have you move your whole body 90 degrees to the right? Any dizziness there?
No.
Back to the center and just pause for a moment. Good, and then rotate to the left. Any dizziness there? Good, and then back to the center. So either you could do these, traditionally in the clinic we do them sitting, but without kind of a swivel chair, you need to do this in standing.
And I still do this even in a stable chair with people. I find that just having them swivel from like their thoracic spine and keeping their head still is another way that you can modify, especially if the person you haven't tested their balance yet. So that's more to see if it elicits dizziness, and also can they dissociate their body and head movements.
Good. And the other thing you could do for cervicogenic dizziness, I don't know if you do any of this, Sarah's just trying to do like a simple self seated traction to see if that lessens dizziness at all, or even just kind of doing a little push down. So those are a couple self-tests.
Yeah.
That might be good just to add to your battery. Another one that we'll sometimes do is just doing a cervical neck flexor endurance test, and that's something you could watch and just time how long they're able to do a little chin tuck with a lift off of their bed. A couple other tools you can have in your tool bag. After we kind of do a lot of those things, I like to get into screening strength and then eventually getting into balance testing. So what we're doing in our clinic is, when you can't have a second person around, you have to be a little bit more cautious about how far you're going to push the person when you're testing for balance. It's really nice if you can have somebody else there to be with them, but that's not always the case. So we kind of err on the lower side, where I'm going to start pretty basic and then slowly work up to see what tests I think the person can do while being safe. So it's constant assessment. I have a full subjective. I've got DHIs and sometimes ABCs in front of me to give me a lot of information before I even go into this balance testing. So the first thing I always like to do is just see if they're even able to get off the chair without using their arms. So can you go ahead and scoot to the edge of your chair, cross your arms over your chest, Sarah, and then see if you're able to stand up. So I'm just going to watch there for the quality of the movement, how easy it is. And then if that looks like it goes okay, I'm going to move into a 5-time sit to stand. So go ahead and sit back down, and I've got my timer here. And I just want to see how quickly you're able to go up and down 5 times. I'll start the timer when I say go, and I'll end it when you're back down in your chair the 5th time. All right, and go ahead. So I'm timing, just watching quality of movement. We've got the chair behind if she does start to feel unsteady at all, which is great. 4, a little off balance there, and then there's 5. So nice standardized tests you can do with the chair behind for safety. It gives you an indication a little bit about their strength, and then starts to tell me a little bit about balance. So after that, it seems like that might be an indication we can kind of move forward. Another test that might be pretty easy to do is just kind of doing a reaching test, sitting at their desk, or even like a standing reaching test. So I'm going to have you go ahead and stand up with your feet together and make sure I can see it from the side. So you're going to rotate about 90 degrees. And then I just want you to kind of reach forward a little bit, like you're reaching to grab something out of your cupboard in front of you. Just kind of watching functional movement, looking for a little bit of limits of stability. Another easy one that they can do, because you can have things around where a person's able to reach out. Good, and she's got the chair there just in case. Good, so just another kind of quick functional screen. So then after that, I'll move into some of more our traditional balance tests. In the clinic, of course, we'd have gait belts on if we felt they were warranted. At home, we have to continue to use our professional judgment as we decide how far to have a person go on a test. We have been doing a fair amount of what we've now called the modified sit-sib, because we are using generally pillows instead of the Blue Airx that we're all used to. So what I will have you do, Sarah, is do you have a corner in the room that you're in there?
Yeah.
Good. What I want you to do is go ahead and get set up in that corner. And you can always put a chair in front of you, but that corner behind you is just going to give you a little safety and security so that if you start to tip a little bit, you can reach out and touch the walls. So this is a really great way to do testing. This is also how we have a lot of our patients do their exercises, is with the corner behind them. And I want to just kind of start with the easiest version of this modified sit-sib. So I'm going to have you go into the arms crossed position, and I want you to start feet apart first. So that way I can just kind of get a gauge here before I put feet together of what our standing balance looks like. A nice, basic, easy position. I can look for sway. There's a shadow on the wall, so I can even watch the shadow to see if it's swaying over to the side of her. And then if I feel like that looks pretty good and I'm comfortable with that, now I want you to put your feet together. And since it looks good, I'm going to go into kind of the more standardized test position. And I'm going to test for 30 seconds, just watching for any sway, seeing if she loses the hand position or takes a step at all. Then if you're able to do that, that looks great. Now can I have you go ahead and close your eyes? Same thing, watching for any sway. That's a little bit more visible there. If you've got people doing this and they have pictures on the wall behind them, that's a really nice, easy way to see sway. Good. And then after 30 seconds, have you take a little break. And traditionally, we'd get out our Blue Airx, but instead what we've been trying with some people is asking them to use pillows. So do you have a pillow with you that you don't mind stepping on?
Yeah.
And if they do not want to step on it, some people have just been putting a towel over their pillow. And then, yeah, go ahead and get on there, feet together, arms across, and then eyes open. So just taking away a little bit of somatosensory input so I can see what it looks like on an uneven surface. I'm not able to gauge how thick the pillow is, but it's just going to show me, is there any difference from the floor to adding in a pillow? And then if that looks good and I feel safe, I'll have her try eyes closed. You know, this is one, preferably it'd be nice to have somebody there with them. And yeah, we've got some vestibular challenges there we've got to work on. You can go ahead and open your eyes. Good. And traditionally in the clinic, if they can get 30 seconds, we do one trial. If they lose balance, then we'll do a second trial and get an average score there. So that's kind of how we're doing our static balance test at the moment. And then the other balance test that we've been trying to do is a 4-item DGI. Again, I won't be able to test gait speed because I don't really know exactly how far she's going to be walking. But let's find a spot. Great, that looks perfect. And setting the computer up on the floor is actually nice, so you can really kind of look at full gait mechanics. Doesn't always work for everybody, but sometimes I'll have them put them on their desk facing the end of a long hallway, on a windowsill facing their room. So first thing I want you to do is just walk towards me at your normal walking pace. Go ahead and turn back and do the same thing. So usually in our clinic, I have them walk 20 feet and then move on to number 2. But at home, I might just have you do a couple laps so I can just really get a good sense of what gait is and making a judgment on gait speed. Good, stop there. Now for the next one, what I'm going to ask you to do is start at normal speed. I'll say fast and you'll increase your speed. I'll say slow and you'll decrease your speed. Go ahead and walk normal pace first. Now go fast. Now slow. Not quite ideal because we don't have a lot of good space here, but let's try again. Go ahead and go walk normal speed. Let's go fast and then slow. So with this, we're just kind of looking at acceleration and deceleration. Since the vestibular system is sensitive to those two movements, I'm just going to see when she changes speed, does anything change about her gait speed? All right, next one, while you're walking, what I'm going to ask you to do, I'll say either left or right, and you turn your head whichever way I say while you're walking. So look straight and walk. Go ahead and start going. Look left and right. Good. Same thing again. I'm going to try it one more time. Look straight and start walking. Look left and right. So if I didn't feel like I could get a really good view on this, which I'm not 100% confident, I might even table it, and next time next time we meet, maybe I'll find a different space where we've got a little bit longer of a hallway and we'll double check this again. But next one I want to just finish up with is up and down. So as you're walking, I'll say either up or down and just turn your head whichever way I say. So look straight and start walking. Look up and down and straight. Yeah, so those two I might like to see from a different angle next time, but for now I can just kind of get a general sense of what head motion does, and also to ask if it causes any dizziness and balance problems. Good, I think those are most of the kind of standardized static and dynamic balance tests I've been doing. I have had some folks who started their therapy before this all happened, and we are trying to do retesting parts of the FGA. Again, it's not standardized, but more just, hey, before you couldn't turn your head and walk and now you can, or before you couldn't do a tandem walk and now you can. I'm not often using that as an initial examination measure on somebody I've never met, but some folks who I were seeing before and we're kind of wrapping up their care, I'm just picking and choosing pieces I feel safe about just to kind of show them that, hey, you have made improvement.
Okay, just to piggyback on sort of the DGI is just gait assessment. So I find that a short walkway actually works fairly well. So where I was just walking was about a 10, 11 foot pathway. So you don't need a lot for just looking at their gait mechanics. And then where I demonstrated was next to a wall, which is nice. So you want to think about just like the location of where you're watching them, especially for the first time. And kitchen islands or counters like worked really well for that too. And then setting people up and putting their camera, laptop or phone on the floor works really well because you can see the whole body usually pretty well until they get very close. So I usually work quite a bit on gait mechanics, and you can see it really well with that kind of setup. All right, so on to BPPV. So we thought we would do this in a real home environment so you could see how it would work in a house. So here we have my guest room. Can you see that? So I usually set people up on the nightstand here. And that works really well in terms of a view of the side of their bed. So we're looking for them to end up here on the side of their bed. So you kind of want to set up the camera so that that's where it's going to end if you don't have a helper. If you have someone who can be there, they can move the camera and video, or they could even help with the person lying back and then holding the camera up to their eyes. I do that occasionally if I feel like I can't get good information from the test without trying to look at their eyes, but it's hard when they're moving and the quality of the camera or the video to actually see the nystagmus. If it's really robust, you can get some good data there. So that's another alternative that I'll demonstrate. So having your patient sit up on the side of the bed, I usually start with the bow test first, because I like to test horizontal first. So just having them sit at the edge of their bed here, and you could position the camera here as well. So I'm bowing down and you can see my eyes. Mm-hmm. I find that I like seeing what position they're in better and making sure that they're in the correct position rather than actually looking at the eyes most of the time. So that would be the bow. Then I would go into a lean here. You see the edge of my bed?
Yep.
Okay. All right, so then you're going to just have them lie back, tuck your chin, and now they're in a lean here. And again, ask them about symptoms, or they could bring their phone right to their eyes right here. Then going into a right roll. And again, if they had a camera, you could bring the camera right here. But if they're alone, I think this nightstand setup works really well. And then you're asking them about their symptoms in each one of these positions and correlating it with the canal. And then I have them pause in the middle and then come over onto their left side for the left roll test. And then going into your hall pikes. So here, again, they're in the middle of their bed, so they're pretty safe. I have them reach back, and that gives me a good idea of how far back they are to the edge of their bed. You want sort of their neck to be enough supported by the edge of the bed here. So if they're kind of reaching far back, that's usually good position, especially if there's not another person to support their head. So I'll ask the person, at this point, I may or may not be able to see them. Just turn your head slightly to the right and then lie all the way back. And then you can see them when they're in this position very well, if they're in the right angle. If they're too far over here, you have them correct. If their nose is straight up, then you have them correct and get into the best position possible. And then do the same thing on the left side. Again, if you have another person to help with this, it's quite helpful for the camera. So if it's my first time assessing BPV, I usually ask if there can be another person to help with the camera, especially if the person is dizzy too. It can be kind of reassuring not to be alone. But that's how I test it in someone's home environment. And then we're really going for symptoms and correlating symptoms with the appropriate anatomy and making sure that those match. And did I get also a return to sit dizziness potentially? If you can't see, if you're not able to have a camera to look at nystagmus and they're not getting dizzy, I will also have them gaze side to side in each position to try to pull out the potential fixation to see if that enhances their dizziness. So tricks that we use in the clinic, if we can't use goggles, are sort of appropriate here as well.
And I think we've had pretty good success with people using smartphones. They just seem to be working better these days. So we're doing a lot of just take your smartphone and lay back. You know, I can't always see, like Sarah said, I can't always see if they're 100% in the right position. But trying to get into that 45 and 20 of extension with the smartphone up there. If it's the first time I'm also working with someone with BPPV, I will ask there to be a helper. And we are still seeing some folks in clinics, so we're making a decision, kind of weighing our options, if it's best for them to come in or if it's best for them to try it at home first. And if we try it at home and we think it might be BPPV, but we can't really get a good gauge on what canal, then we are asking them to come in. Another way that we're also screening is just by doing the side lying test, which is really easy to kind of do by yourself. So the side lying test is a really good modification, and it's really just one repetition of a Brandt off. So turning your head to the left and then laying on your right side, nystagmus there, sitting back up, and same thing on the other side. And then I like what you do for bow and lean. I would be using that as well to test my horizontal canals.
And then sometimes I'll do over telehealth, I'll have them rate their symptoms because I can't always see the nystagmus. So if let's say I test the right hall pike first and they rated a 2 out of 10, but then I have a left hall pike is, oh yes, this is like an 8 out of 10, then that gives me more data as well, rather than just, are you dizzy? So being a little bit more thorough with maybe the intensity of symptoms will help you correlate your data. And again, you're just trying to gather the best data you possibly can. There's lots of patients who can't tolerate goggles in the clinic, so you have to modify in the clinic. There's patients who close their eyes, all sorts of things where you have to make modifications anyway. So this is another level of your clinical decision making and gathering of information.
Yes, it is. And making sure, you really have to think through, using your clinical decision to make sure it's the most appropriate to test them at home. And one thing I'll say is, as of this recording, Medicare has not approved telehealth for physical therapists. So most of the folks that we're seeing are 65 and under. And that kind of bodes well to be able to do this where that population may not be able to move through some of these things that we've been talking about today.
Yeah.
Yeah. Let's see if, is there anything else on BPPV? I think that's
I don't think so.
good. And then, just subjective symptom scales are really great. With our initial paperwork, we send out a DHI, and then typically at the end of our sessions in clinic, we always would give out the ABC. So I've just been emailing those to folks and asking them to either, with the DHI, it comes through our EMR, but the ABC, I sometimes just have them fill it out and email the score back to me. So there's lots of other subjective symptom scales out there that you could incorporate into your practice as well.
Yeah, I think one thing we didn't go over today is just that Sarah touched on it, but we didn't actually talk exactly about it, is your subjective has to be very thorough, and that will guide you more than you realize. So that really will guide you of what's going on and what you need to test. So taking a very thorough subjective initially and trying to figure out what's going on before you even do the testing is, I think, probably what we do at this point, rather than go through an entire evaluation, just like you would in the clinic, kind of narrow it down. So remember to use that as your data point as well. And then also thinking about, like Sarah said, you always you might have the potential to bring the person back into the clinic if you feel like you need to. So just reassessing each session. So if I'm treating someone with BPV and I got sort of vague, or they were symptomatic fairly equally on both sides, let's say I'm treating horizontal and I don't feel confident and I couldn't visualize whether it was geotrophic or apogeotrophic, and I'm not confident in which side, and I've treated it now 2-3 times, that's definitely somebody I would bring into the clinic for a goggle assessment, or say we need to switch strategies here because I'm just not able to get as good data as I feel I need.
Yeah, we brought people in where we've done the test, even with somebody else there, and it's been really strong BPPV, and we just didn't feel real good about them going through the treatment, given how strong their symptoms were with some of the nausea. I'm always worried about that last position when they have to roll over, popping their head up and maybe migrating the debris. So we've also made the decision that this looks like it's pretty strong. I think coming in is going to be better for you to treat this than doing it over a televisit, but it's kind of on a case-by-case basis. Some of our return BPPV folks who have done this before, they've been through lots of maneuvers with us. They just want confirmation that it's in this canal again. We figure that out, and then those folks are able to walk through pretty easily.
And I know just from experience 2 days ago is we had a telehealth, one of our therapists, telehealth BPV assessment for the very first time. And she couldn't recreate the vertigo, but the patient was still having vertigo at home. So we had her come into the clinic and use the goggles. And I'm pretty sure, and she had very robust nystagmus and symptoms. I'm pretty sure at home, she was guarding right out of the position enough to not be able to trigger. Whereas at home, in the clinic, you have their hands on them. You can really gauge the position well. That's why I think it's so important to be able to establish your view of the patient to make sure that they're really in the best position, and then using that determination of is the person really, is it correlating with what I would expect? So for hers, it was super straightforward, but I'm sure, and I said to her, I'm pretty sure it didn't happen because you checked your chin instead of extending, and it looked extended, but so just know that people want to cheat, not because they want to cheat, but because they don't want vertigo. And so that's something to watch for on telehealth as well.
Yeah, that's great. And prior to this, our model with telehealth is we made people come in for in-person evals and then did their treatment over telehealth. That model has gone away a little bit. We're still, if the patient's comfortable, we have precautions in our clinic for in-person visits. So we are still offering that. And just because I sometimes feel we can get a little bit more established, especially with BPPV in person, but that's not always the case for everybody. And we've been doing a good job of telehealth evaluations and clinical decision making.
Good.
All right. Thank you.
Thank you. Good to see you, Sarah.
You too.